do it from the medial and the lateral approach, and it's very easy to obtain an arthrocentesis sample. But generally speaking, the joint inflammation, the erythema and diffusion, like what they describe as synovitis, is always inflammatory. In non-inflammatory, you see bony proliferation. The morning stiffness is usually inflammatory, and the non-inflammatory is less than an hour. So if they give you stiffness less than an hour, think about osteoarthritis. Systemic symptoms almost always associated with like inflammatory diseases. Synovial fluid typically is pretty bland in the non-inflammatory, less than 2,000 leukocytes, and definitely less than 50 polymorphonuclear cells. And there is inflammation. In the urgent care, you can always send an ESR CRP. It takes about an hour. You guys know how we do an ESR? You guys remember from physiology, how do we do an ESR? So basically, they just put a little bit of blood sample in a capillary, and they wait for an hour. And they just measure the amount of sedimentation of the blood in an hour period. So make sure that you know the false positives for ESR. Anemia is one of them. And if you have less red blood cell mass, the cells have less negative charges, and they're more likely to precipitate. So anemia, if you have severely anemic patients, those patients, they have high ESR. So make sure you know the false positives for ESR. So always in the urgent care, you do an ESR CRP. Rheumatoid factor and CCP, they don't really come back right away. But make sure you send those things. In the x-rays, definitely you see erosions, except on lupus. But in the non-inflammatory, you see osteophytes, you see the subchondral sclerosis like we have right here in this picture. Okay? All right, go ahead, please.
67-year-old man comes for evaluation of knee pain. 2 months ago, he developed pain in the right knee that worsened when he played tennis and was relieved with rest. He now has pain with most activities and occasionally at rest that is often associated with swelling. He has no morning stiffness. Maximum doses of acetaminophen provide only mild to moderate relief of pain. 1 year ago, he was diagnosed with coronary artery disease and myocardial infarction and underwent intracoronary stent placement. He also has hypertension and hyperlipidemia. Current medications are atorvastatin, atenolol, isosorbide, mononitrate, and low-dose aspirin. On physical exam, blood pressure is 130/80. Cardiac exam shows an S4, normal S1 and S2, no murmurs or rubs. Range of motion of the right knee is painful and limited. The remainder of the musculoskeletal exam is normal. Radiograph of the right knee shows medial joint space narrowing, subchondral sclerosis, and osteophytes. Which of the following is the most appropriate next therapeutic step for the patient's knee pain?
So what's the diagnosis, number one? Osteoarthritis, right? We all agree, it's very clear-cut, all the signs and symptoms. All right, so what's the first line treatment for osteoarthritis?
Which is ibuprofen.
Acetaminophen. That's universally, like when the patients, these guys are already failing acetaminophen. So the question is geared towards like, what do you do next? If somebody shows up in your clinic, they already failed acetaminophen. The FDA, it's important that we cover this because you guys are going to be in the primary care setting. We don't prescribe NSAIDs for people over the age of 65, period. We don't prescribe it. I know some doctors do it, but it's not a good practice. NSAIDs are associated with significant systemic toxicities, including the risk of bleeding peptic ulcers, the risk of chronic kidney disease, and many other different types of renal diseases associated with NSAIDs, chronic NSAIDs use. And in this patient particularly, you do not want to prescribe a lot of NSAIDs because he has a history of coronary artery disease. So coronary artery disease, like Celebrex, like you guys are too young to remember Vioxx, but Vioxx was taken out of the market because it significantly increased the risk of in coronary thrombosis and death. So Celebrex is the last selective agent that we still have from that family. We used to have so many until there were so many bad news regarding the use of these medicines. But the teaching point for this question is, number one, you don't prescribe NSAIDs in the elderly. Number two, you don't use them if you have a patient with coronary disease. Number three, an arthroscopic lavage and debridement is not going to help. This is not a meniscal injury. And the total knee arthroplasty, yes, that's the last resort for the management of severe osteoarthritis. There are many joints that can be replaced nowadays, but probably the safest thing that you can do for this patient, given his age, is to prescribe tramadol. Tramadol is a narcotic. Just make sure that you know it's habit forming. So you tell the patient you're going to use tramadol only if you have to. You're not going to replace the Tylenol. You should still be taking the Tylenol as the management. Other strategies that I tell my patients is that in addition to losing weight and physical therapy and all the things that I'm going to cover later, I can prescribe things like capsaicin cream. Have you guys ever prescribed or have you ever tried capsaicin? So capsaicin is actually made out of the chili plant. And if you apply capsaicin, it feels very hot, like for the first 10 minutes. But it actually is a very effective medication to mediate, to decrease pain. It inhibits substance P, which is one of the neurotransmitters involved in the pain pathways. So it is very cheap, is very minimally toxic, and the only complaint your patient is going to tell you is like it feels very hot, but you're just going to tell them that that's expected. And another thing that you guys can prescribe, which there are some studies showing that there is a benefit to it, is either using glucosamine and chondroitin. It's not going to harm the patients, and it's very safe. Even if your patient has liver or kidney disease, you can prescribe it. Okay, so tramadol is probably the next step, and not to replace the Tylenol, but in addition to, and only to be used when absolutely needed. Okay, so weight loss is fundamental. You're going to have all these patients that they come to you telling you, doctors, my knee hurt. And you're going to be so surprised that they don't understand why the knee hurt. And the lady's probably like 200 pounds and a very short lady. I have so many patients coming to me telling me my knees hurt, and they miss the picture. Your knees are hurting because you're overweight. So weight loss is fundamental. You have like so many different assisted devices, physical therapy for quad muscle strengthening. So that should be always part of the management. Refer your patients to physical therapy. Again, I already explained the NSAIDs. Second line, the tramadols or the opiates. Injections, there's so much you can do. You should never do it more than every 3 months. Like every time you do an infection, there is a risk of introducing an infection, causing a tendon rupture. And if your patient has systemic diseases like hypertension and diabetes, they do have an impact on diabetes and hypertension control. So make sure you don't do it like very, very frequently. Nowadays, orthosurgeons, they inject some of these hyaluronate, I don't even know how to pronounce it, but it's just basically synthetic cartilage that it does help patients with advanced significant disease. And you avoid steroid injection if you don't know for sure that this is osteoarthritis, because if you have a septic joint and if you put the steroid there, it's like giving vitamins, and this is malpractice. Okay, so, and then lastly, surgical when all the other options have been exhausted. Typical DIP joints, remember, osteoarthritis, they're called the Heverden nodules, and you can also see it when you have PIPs, you think about osteoarthritis, and you can also see it in rheumatoid arthritis and lupus. In the MCPs, you think about rheumatoid arthritis, SLE, or hemochromatosis. Which patients develop hemochromatosis? Do you guys know? Transfused patients, but there is also a genetic condition like this. There's a test that you can screen for. Say it again. Wilson's disease can develop it. Yeah, but there is a primary hemochromatosis patients. Like they may give you a patient like a clinical case on your boards with evidence of iron overload. They may develop diabetes. They may have like a hyperpigmentation, right? The bronze diabetes, and these patients actually they very frequently they require like either a liver or a heart transplant because they deposit anywhere. All right, you're next.
A 52-year-old woman is evaluated for a 4-day history of swelling and pain in the left ankle. She has a 6-year history of Crohn's associated with joint involvement of the knees and ankles. Her last disease flare was 2 years ago. At that time, she was treated with a 3-month course of tapering prednisone and infliximab. She has continued taking the infliximab. She's also been on avopiravir for 3 years. Physical exam temperature is 100.5, pulse is 88, respiration is 18. The left ankle is warm and swollen, and passive range of motion with this joint elicits pain. The knees are mildly tender to palpation bilaterally, but do not have effusions, warm for erythema. Range of motion of the knees listed as crepitus bilaterally. The remainder of the MSK exam is normal. Arthrocentesis of the left ankle is performed and yields 3 milliliters of cloudy yellow fluid. The synovial fluid leukocyte count is 75,000, approximately 92% neutrophils. Polarized light microscopy of the fluid shows no crystals and gram stain is negative. Culture results are pending. Which of the following is the most likely diagnosis? Septic arthritis.
You guys all agree? Any takers? Any other takers? So leukocytes of 75,000 is very abnormal. Very abnormal, right? And the polarized light, you're looking for crystals, right?
Yeah.
And the gram stain is negative. Any other takers? Septic arthritis. Okay, I'm gonna cover in a second. So why don't we do the next?
Also, it had crepitus, right?
Crepitus, yeah. Yeah, so that's actually one of the things that you do not want to miss if you're an urgent care doctor. It's a nightmare. Okay, go ahead.
An 82-year-old woman with a 2-year history of osteoarthritis of the knees is evaluated for persistent swelling and pain of the right knee of 3 months duration. She now uses a cane for ambulation and is unable to go grocery shopping. Medications are naproxen and hydrocodone acetaminophen as needed. On physical examination, vital signs are normal. The right knee has a large effusion and a valgus deformity. There is decreased flexion of the right knee as secondary to pain and stiffness, and she is unable to fully extend this joint. Range of motion in both knees elicit coarse crepitus. Laboratory studies reveal a serum creatinine level of 1.1 milligrams per deciliter and a serum uric acid level of 1.2 milligrams per deciliter.
8.2.
Oh, 8.2.
Is that normal or that's high or?
High.
It's a little high, not terribly high. Can you have gout with a normal uric acid?
Yes.
Yes. So it's just, we screen for it, but you can still have gout.
Radiograph of the right knee reveals a large effusion and changes consistent with end-stage osteoarthritis. Aspiration of the right knee is performed. Synovial fluid leukocyte count is 3,200 microliters. Polarized light microscopy of the fluid demonstrates rhomboid-shaped weakly positively bifringent crystals.
That's the $5 word that you guys need to concentrate if you see this. Rhomboid shape, weakly positively birefringent crystals. Okay.
Results of gram stain and culture are pending.
Which one of the following is the most likely diagnosis? CCPD, right? We'll agree? Okay, so for gout, actually I have a thing. So this is slide. You guys review it. Make sure you know it. You're going to be working in primary care and the urgent care. You need to know this. So if you have like some sort of arthritis, you don't expect to see like either you have lupus or traumatic arthritis or any type of osteoarthritis. You're not expected to see any crystals. You're expected to see very few WBCs. If you have RA, that's more like erosive and inflammatory, same as the spondyloarthropathies. You can see anywhere from 5,000 to 50,000 WBCs and no crystals, and the glucose is normal or low. So gout, you're gonna see the needle shape, the monosodium urate is strongly negative in the polarization microscopy, and the glucose is normal. So pseudo gout, that's what we call CPPD, and typically it happens in elderly people, but you can see it in any age group. The fluid can be anywhere from 5,000 to 75,000, but what makes the diagnosis is actually the microscopic polarization light. That's the reason why you can't discharge a patient without doing both the gram stain and the polarization, because that's going to rule out the other two things. And a septic arthritis, you can have like severely elevated WBC count, primarily polymorphonuclear, and the gram stain can or cannot be abnormal. Like the example I gave you, we said that it was actually the one that you did. Actually, I show you that the gram stain is negative. So remember, if you see a negative Graham stain, doesn't mean that you may have a septic joint. And when you suspect that you're dealing with a septic joint, you better get the orthopedic surgeon involved, and he can make the decision whether or not he wants to do a joint washout. It's an orthopedic emergency. If you don't do it, patients can be left with permanent joint damage. Okay, why don't you go next? Thank you.
A 28-year-old woman is evaluated in the emergency department for a 1-day history of nausea, vomiting, and blood correction. For the past several months, she has had fatigue and malaise. For 2 weeks ago, she developed arthralgia involving the hands and feet, intermittent pleuritic chest pain, and abdominal pain. She also has a 1-week history of low-grade fever and worsening of her abdominal pain. On physical exam, she appears ill. Temperature is 38.3 degrees Celsius. BP is 145/85. Pulse rate is 112. Respiration rate is 16. There is an erythematous rash over the cheeks and forehead. Cardiopulmonology pulmonary exam reveals a friction rub. Abdominal examination reveals mild distension, rare bowel sounds, and diffuse abdominal tenderness. The wrists are tender and mildly swollen. Bilateral 1+ peripheral edema is present. A stool specimen is positive for blood. Labs, hemoglobin 8.9, platelets 48,000.
Let's just cover the abnormal things. So 48,000. So the creatinine is abnormal, right? Okay. Decreased complement, so look always for that. ANA is strongly positive. So, like anywhere from anything greater than 1 to 40, I think is positive, but this is strongly positive. Her Hep B surface antigen is negative. Why am I listing the Hep B surface antigen there? What is the systemic rheumatologic disease associated with Hep B? You're going to be asked that question on your boards. I actually have a slide. Protein nodulism. Very good. All right. So the UA, very abnormal, right? This is what we call an active urine sediment. You're not supposed to have protein, leukocytosis, and this much heart disease unless you're having a really bad UTI. But if you don't have a UTI, this is quite abnormal. This patient guaranteed needs a renal biopsy. And every time you read RBC cast, that's extremely abnormal. So this needs to be evaluated further. So she's leukopenic, ESR very high, haptoglobin is kind of low, LDH is high, ANCA is negative, anti-double-stranded DNA is positive, and the direct Coombs test is positive. So this person has how many criteria? A lot, right? Probably all of them, right? So
they're like 14, right, or something.
They're 11. Well, you can stretch a little bit. You need 4 out of 11, yeah, to be able to diagnose it. But we all agree that this person has lupus, right?
Yeah.
Yeah. So we all know this. This is probably like one of the tortures of medical school, the MD soap. So the mucocutaneous criteria, the photosensitivity, the malar rash, the ulcers can happen actually in the mouth or in the genitals. So make sure you ask the patient both. Discoid rash, the organ systemic criteria. Remember, non-erosive, 2 more joints, or they're symmetric. Patients have serositis, either it can be pericarditis or pleurisy. And renal, patients can present with either subnephrotic or nephrotic proteinuria and abnormal urine sediments. And when you suspect renal biopsy, you always biopsy. When you suspect renal involvement, you always biopsy, because there are 6 different types of involvement of lupus in the kidneys, and 3 of them we treat them with immunosuppressive medications. We treat type 3, which is the focal proliferative lupus glomerulonephritis. Type 4 is the diffuse proliferative lupus glomerulonephritis, and type 5 is the membranous lupus glomerulonephritis. The others we don't treat. The first 2 are mild involvement, and we just need to monitor the patients, and we rebiopsy as needed. And the type 6 is diffuse sclerosing lupus glomerulonephritis. There's nothing you do there. The kidneys are gone. Pretty much when you see that, the kidneys have like interstitial fibrosis and tubular atrophy. There's nothing you do there. So blood changes. We talked about anemias yesterday. Like this person has a hemolytic anemia with leukopenia and thrombocytopenia. And neuropsychiatric features. One of the interesting cases when I was a resident, we admitted a patient that was seen multiple times in the ER with pruritus, And the last time they brought him in because the family mentioned that the guy not only had the pruritus, he didn't have like a distinct rash, but he was like very pruritic. And the family brought him in because they couldn't take care of him, and they claimed that the patient was having personality changes. And when we did a good exam, we noticed that he had like a bunch of lymph nodes. We sent everything, and we did a core biopsy of one of the lymph nodes, and the guy had lupus, which is very interesting. It was very educational for me to always remember that case. Because lupus, if we get taught in med school like syphilis is the great mimicker, I think lupus is the great mimicker. You know, lupus, you're gonna see the classic textbook question or board question, and you're gonna see patients with very bizarre presentations. So when you don't know what the hell is going on, always send an ANA. And an ANA is a screening test, it's not a diagnostic test. And there are different settings where you can get a falsely positive ANA, and I'm gonna talk about the antibodies that are associated with the highest. So the lab value criteria, you have the double-stranded DNA, it's highly specific. And it also, when you have a double-stranded DNA, positive double-stranded DNA, you also think about renal involvement. Most patients with renal involvement, they have a positive double-stranded DNA. And the anti-Smith antibody is actually confirmatory. Can you have lupus negative ANA? Lupus, ANA negative lupus? Can you? Yes, you can. It's very rare. It's 1%, very rare, but you don't actually see a lupus negative anti-Smith, or, you know, and you can also see the antiphospholipid antibodies complex. You can go ahead. Thank you. And okay.
Do you need to have all three of those?
You need to have 4 out of
The lab values down
You
below?
have to have
at least one of them.
meet
Oh,
the lab.
so it's just one, and you don't have to have all three positive?
You don't have to have all 3 positive. Yeah.
Okay.
Yeah, but these are like, I listed all the possible diagnostic,
Because it's 4 out of all,
Right.
including the one of the. if you have-
including one of the lab value criteria. You need to have at least one of the lab value criteria.
Okay.
Okay, so these are the antibodies in the clinical association. So, the ANA is usually sensitive, but it's non-specific. So, and on your boards, if you don't suspect systemic inflammation or systemic rheumatology condition, do not answer ANA. We try to avoid, for practicing clinicians, we try to avoid ordering ANA because that basically opens a can of worms that you're going to be doing a bunch of workup unnecessarily. You only do it if you suspect that there is a systemic process. The same thing on your boards. Did you guys were here when I gave the hypertension talk? Were you guys here? Okay, so remember, like for adrenal incidentalomas, if you're like on your boards, they're gonna trick you to answer, like you order an MRI of the adrenal glands. You don't order an adrenal gland MRI unless you have biochemical evidence of aldosterone excess. Same thing with this disease. We're trying to avoid doctors to do like unnecessary workup. And on the boards, they test for this kind of stuff. So ANA, we only order if you suspect systemic, and at least you have some of the criteria. But some doctors, the patients go in, oh, my hand hurts, and they send an ANA. There's no reason to do that. So that's not good medicine. That's what I'm trying to say. So these are the disease associations with the most commonly sent antibodies. So the anti-RNP, you see it in the MCTD, which is mixed connective tissue disease. And the anti-SSA and SSB, you see it in Sjogren's, but you also see it in the subacute cutaneous lupus erythematous. Like this is a type of lupus that is limited to skin involvement. And the antiphospholipid antibody, there's several antibodies, I'm going to list it in a different slide. And the antihistone antibody for drug-induced lupus. Okay? So when you're following disease activity, you don't send an ANA, you always send a double-stranded DNA. Like when I see my lupus nephritis patients in clinic, when I bring them for follow-up, I send a complement level and double-stranded DNA. That's actually indicative of disease activity. Okay, who's next? You're next. This time.
35-year-old woman with 3-year history of lupus is admitted to the hospital with a blood pressure of 180/90 and evidence of acute kidney injury. Her last lupus flare was 1 year ago, and she is currently asymptomatic. 5 years ago, she developed DVT and PE after an automobile accident. She's had 3 first trimester miscarriages. Her only medication is hydroxychloroquine.
So let me stop there. So you're going to hear this history about lupus. Lupus can be triggered by a major event, stressful event or a car accident or some trauma. like the symptoms can just start showing up. So that's why I put it there so you guys remember that. Okay.
On physical exam, temp is normal, blood pressure is 200/96, pulse rate is 102, respirations 20. Cardiopulmonary exam is normal except for an S4.
Gallop. Mm-hmm.
Abdominal exam is unremarkable. There is no rash, lymphadenopathy, or oral ulcers. Let's see. Her platelets are a little bit low. Her creatinine is very high. Her ANA is high. I don't know what speckled means.
It's the pattern. I mean, before we used to pay attention to that, like, yeah.
IgM, anticardiolipid antibody, more than 100. IgG, same thing. Lupus anticoagulant positive, and the UA, 2 plus protein, 1 plus blood, 2 to 3 lymphocytes, 3 to 5 erythrocytes, and the urine protein creatinine ratio is 1.2. A direct Coombs test is negative. Cerebral blood smear reveals rare schistocytes. Renal ultrasonography reveals normal sized kidneys with no obstruction of renal veins.
Okay, let me stop there. You guys weren't here yesterday. Every time you see schistocytes on your boards, that's very abnormal. You need to rule out like MAHA, like microangiopathic hemolytic anemia, or like the same spectrum of disease is called TMA, thrombotic microangiopathy, and the kidney is a favorite target for this type of disease. So that's why this patient ended up getting a renal biopsy. Mm-hmm.
Which shows capillary congestion and intracapillary fibrin thrombi consistent with thrombotic microangiopathy.
TMA. So this is not lupus in the kidney. This is a separate disease process called TMA. Mm-hmm.
Immunofluorescence testing reveals deposition of fibrin, but not IgG, IgM, or C3.
Which is classically what we see in the immunofluorescent on a renal biopsy. Remember, the renal biopsies, we send it for 3 components. We send them for light microscopy, for immunofluorescence, and for electron microscopy. For lupus nephritis, we always call it the full house pattern because we see deposition of IgG, IgM, and C3. So that's, I'm specifying there that we don't see any of that, just to make it distinct that this person is dealing with a TMA, a thrombotic microangiopathy. So which of the following is the most appropriate next step in this patient's treatment? How do you treat TMA? What's that? Any other takers? It's a hard question, right? So this lady has actually, she has a life-threatening process going on, and you need to act very promptly. Like right now, I'm pretty sure she's clotting everywhere in her body, because we have evidence of like the TMA in the kidneys, but this happens systemically. So you're right. The first thing you do is you heparinize these patients. The plasmapheresis is an option, but when the patients are actually having like catastrophic, like TMA, like sometimes this is one of the alternative treatments, but it's not the first line treatment. You always need to anticoagulate these patients right away. So the antiphospholipid antibody syndrome is going to be on your boards. You diagnose it by the presence of antibodies plus either a venous or an arterial thrombosis. So if you have a patient showing up, they give you a patient showing up with an unusual type of thrombosis, like arterial. Like the other day, I got called by the ER. One of the patients presented with abdominal pain. They did a CT with IV contrast, and the lady had severe, like a significant, like probably 2/3 of the kidneys were involved by a renal infarction. That's pretty abnormal. When you see this type of arterial thrombosis, you have to think about either this person has AFib, some sort of like thromboembolic phenomenon, either a history of trauma, which she didn't have, or hypercoagulable disorder, including the antiphospholipid antibody syndrome. You can still have the antiphospholipid antibody syndrome without having lupus, but one of the disease association of this disease is actually with lupus. So on your boards, if they give you like this history, this person had SLE, and then we found out that she presented with a thrombotic complication. So, but it's important, your job as the internist on the case is to determine if there's any neurological or any renal manifestations, because the management is very different. because you need to make a decision whether or not this person needs to be anticoagulated, and it needs to happen like right away. You need to put them on a heparin drip and start them on Coumadin. Okay? Very good. Go ahead.
A 42-year-old woman is evaluated during a follow-up visit for a 3-year history of polyarthralgia involving the metacarpophalangeal and proximal interphalangeal joints of the hands, wrists, elbows, shoulders, knees, and ankles, accompanied by occasional swelling of the wrists and hands. Over the past 3 months, her joint symptoms have worsened, and she has had intermittent mouth ulcers, redness of the cheeks, and pain on expiration. She was started on naproxen 1 week ago, and she states today that her joint and chest pain has decreased by approximately 80%. She takes no other medication. On physical exam, her temperature is 37.1, blood pressure is 134/82, pulse is 84, respiration is 16. Cardiopulmonary examination is normal. There is a mild malar erythema, and there is 1 ulcer on the palate. Shabby cervical and axillary lymphadenopathy is present. Abdominal examination is unremarkable. Examination of her hands reveals ulnar deviation and metacarpal subluxation. The deformities of her hands are reducible, and she has full range of motion of all joints. The wrists and ankles are mildly injured. 12.9, glucose 6, 3 minutes out, cancer 42, C340, C410, anti-titer, I guess you consider it high, yeah. Anti-ro, antibiotics positive, which is one is most appropriate treatment for this patient.
A hard question, huh? Any takers?
No additional treatment.
No additional treatment? Hmm? You know why? Because lupus, if you don't have like severe involvement, like you were saying, no additional treatment, you treat the manifestations with Plaquenil, like the joint manifestations with Plaquenil, and the rash also responds to Plaquenil. So always remember that rheumatoid arthritis first is methotrexate. Like Plaquenil can also be used when you fail methotrexate. Lupus is always Plaquenil. If you have other major organ involvement, you need to go to a more aggressive regimens. I'm going to list them here. So the flares of lupus you treat with corticosteroids, and for the steroid-sparing options, you either do Cytoxan, Cellcept, or azathioprine. You know, azathioprine, it's Imuran. Azathioprine is a great medication, but the problem is that if you take it for many years, guarantee you're going to develop a squamous cell cancer of the skin. And that's one of the precautions that you need to advise your patients if they take Imuran. Or like I was just telling you guys the other day, renal transplant or any type of transplant patients, the single most common cancer is the skin cancer, and it's because all the transplant regimens involve one of these anti-proliferative agents, either Cellcept or Imuran. So make sure you always advise them to wear long sleeves and sunblock. But if you have like major organ involvement like the kidneys, you have to treat these patients with Cytoxan. It's like a chemotherapy, monthly chemotherapy. And you will continue the Plaquenil probably indefinitely with once a year at least eye examinations. And you can even treat it with pregnancy. Remember always that the Plaquenil is safe in pregnancy. Okay? All right, go ahead, James.
A 45-year-old woman is evaluated for a 2-week history of pleuritic chest pain. She has a 6-month history of arthralgia and a 2-month history of myalgia and mild proximal muscle weakness. She had difficulty climbing the stairs, rising from a chair, and removing dishes from a high cabinet. She also has a 10-year history of Raynaud phenomenon. On physical examination, temperature is 97.6 degrees, blood pressure is 125/78, pulse rate is 90, and respiration rate is 18. Cardiopulmonary examination is normal. Abdominal examination is unremarkable. There are healed ulcerations on the second and third fingers of the right hand. There is no synovitis. Proximal upper and lower extremity muscle strength is 4 out of 5 and associated with mild muscle tenderness. Lab studies include ESR is elevated at 63, CK is moderately elevated at 896, AST slightly at 98, ALT 67, ANA titer is 1 to 2560, and chest X-ray shows blunting of the costophrenic needles. Which of the following antibody assays will confirm the most likely diagnosis?
What do you think this person has? I'm sorry? What do you think, James?
I don't know, as soon as I read the myalgia and proximal muscle weakness with climbing the stairs, I thought of myositis or something.
Well, it has Raynaud's, it has like the proximal muscle weakness, they have like these heel ulcerations in the second and third fingers of the right hand. So if you have a myositis, what kind of test do you order?
I guess antimitochondrial, but I don't remember.
Any other takers?
Maybe the subclass one.
I know it's a hard question, but I want you guys to, this is a classic like connective tissues disease. We're entering like a very specific field in rheumatology that probably not two rheumatologists can agree how to manage these patients. But you know, typically on your boards they're gonna give you probably like scleroderma. It's probably the more likely to be on your boards. And Sjogren's, you're gonna be heavily tested on that one. So, but the mixed connective tissue disease is like the anti-RNP positive, anti-ribonucleoprotein. So you think about lupus-like disease or myositis may evolve to look like a scleroderma, and eventually these patients can actually they respond very well to steroids. For Sjogren, actually one of the disease association with Sjogren is always lymphoma. So think about it. I told you about rheumatoid arthritis and lymphoma, but if you have rheumatoid arthritis and Sjogren, your risk of lymphoma is like 40 times higher than the general population. So typically the anti-SSA and SSB, and there is infiltration of lymphocytes that destroys like the lacrimal and the salivary glands. Okay, so when you have a patient who like maybe this person has lupus, maybe this person has something else, including muscles, so you order the anti-RNP. Okay, so anti-Smith is confirmatory for lupus. The anti-RNP, you start thinking about like more like mixed connective tissue disease. Okay, go ahead.
The 60-year-old woman is evaluated for a 4-month history of progressive fatigue and dyspnea on exertion. She does not smoke cigarettes and denies chest pain, palpitations, dizziness, or syncope. She has a 12-year history of limited cutaneous systemic sclerosis. A screening cardiopulmonary evaluation 3 years ago was normal. She also has gastroesophageal reflux disease and Raynaud phenomena, and intermittently develops ulcers on fingertips.
Mm-hmm.
Currently, medications are amlodipine, omeprazole, and nitroglycerin. On physical exam, temp is 37 Celsius, blood pressure 120/80, pulse rate 84, respiration rate 16. Cardiac exam reveals a loud pulmonic component of S2 with thick splitting and a 2 out of 6 early systolic murmur at the lower left sternal border that increases with inspiration. The lungs are clear to auscultation. The abdominal exam is unremarkable. Sclerodactyly is present, and pitting scars are visible over several fingertips. There's no peripheral edema. Complete blood count and erythrocyte sedimentation rate are normal. EKG shows evidence of right ventricular hypertrophy. Chest radiograph shows no infiltrates. FVC 84% predicted. FEV1 over FVC is 0.8. DLCO is 44% predicted. Which of the following is the most likely diagnosis?
Okay, so we know that this person has a limited form of cutaneous systemic sclerosis. So that usually some patients with this presentation, they have a very stable disease over the years, but it sounds like this person is developing a pulmonary complication, right? Mm-hmm. And the most common pulmonary complication of scleroderma is? You guys know? Yeah, like the old exam that I described there is consistent with pulmonary arterial hypertension. So every time you have basically systemic sclerosis, you have to think about, like, is this diffuse or this is limited? If it is diffuse, actually you see diffuse organ involvement. You know, if you guys are probably gonna get this one. Last time I took my boards, they tricked me with this. I didn't know what it was at the time. So, but if they give you anything like what they call it, like the watermelon stomach, like the gastric antral vascular ectasia, it's associated with scleroderma. So you need to know this. Every time you see this, you suspect scleroderma. Okay. So basically the appearance on endoscopy looks like a watermelon, like the lines of the gastric mucosa. And another thing that's very important for you guys to know that is heavily tested on your boards is that if you suspect a scleroderma renal crisis, you have to treat these patients with an ACE inhibitor, even if they're pregnant, because that's how you prevent these patients from going into irreversible renal failure. It's a renin-dependent disease. Yeah, like some of the patients with diffuse scleroderma, when they have like lung involvement, it's very difficult to treat. And some of them, when they develop like ILD, interstitial lung disease, and pulmonary hypertension, that can actually progress and it can actually be fatal. And these patients are less responsive. It's a different story with limited type of scleroderma. Now we have like these medications that make it treatable. They can ask you about the CREST syndrome. Have you guys heard about the CREST syndrome? So the calcinosis, Raynaud's phenomenon. How do you treat Raynaud's, by the way? Just avoid, calcium channel blockers and avoid cold temperature. They may develop like lower esophageal dysfunction, sclerodactylia, and telangiectasias. That's the classic. And these patients, when you screen, if they give you a choice to answer, this is the antibody that you usually send, the anti-centromere positive antibody. Okay? It's a busy slide. All right. This one I already gave you. Yeah, it's a Wegener. We don't call it Wegener. You guys know why?
He's a Nazi.
He's a Nazi, yeah. So let's go to the second one. There are actually the other three one. Trick Strauss also. We don't call it that way.
So, wouldn't it be good to give a horrible disease name to somebody that was a Nazi?
Yeah.
Best, like,
it's a good idea.
This is some heart attack, and we're gonna name it. Like go rings or something.
Go ahead. This is also ANCA, but this is a question related to ANCA. Go ahead, read this one.
An 82-year-old woman was evaluated for a flare of polymyalgia rheumatica manifested by aching in the shoulders and hips that began 2 weeks ago. She also has fatigue and malaise. She was diagnosed with polymyalgia rheumatica 8 months ago. At the time, she was prescribed prednisone 20 milligrams. Her symptoms promptly resolved and her prednisone dosage was gradually tapered. 4 months ago, her prednisone dosage was decreased from 7.5 milligrams to 5, and her symptoms returned. Her prednisone dosage was then increased to 10, followed by a slow taper. Her prednisone dosage was most recently decreased from 7 to 6, which is her current dosage. She also takes calcium and vitamin D supplements and a bisphosphonate. On physical exam, vital signs are normal. Range of motion of the shoulders, neck, and hips elicits mild pain. There is no temporal artery tenderness, which of the following is the most appropriate treatment for this patient.
She has PMR, right? I put this question because it's not uncommon that you see these like, oh, I went from 7 to 6 milligrams, and that's how we try to find the sweet spot where the patient's symptoms are controlled and we're not exposing the patients to systemic side effects from prednisolone. So basically, like you can add a little bit more steroids. Her current dose of prednisone is 5 milligrams. You can add a little bit more, and then you add a methotrexate. Why? Because some of these diseases actually, you know what happens when you don't treat polymyalgia rheumatica? One of the complications? You guys remember? One of the complications? Temporal arthritis. And if you get that on your boards, what's the next step in management? Right. And you need to admit those patients and do what?
Biopsy.
Temporal artery biopsy. So make sure you don't get it wrong. They're going to ask you that question. So this is actually, that question is the, let me see. Go ahead with this one. We're almost done. We're like 3 or 4 more slides. We're done.
20-year-old woman is evaluated for a present history of malaise, fatigue, myalgia, and occasional occasional headaches, and an unintentional 4.5 kilogram weight loss. 5 weeks ago, she began to develop pain in her arms and legs when exercising at the gym. This pain resolves with rest. On physical examination, temperature is 37.3 degrees Celsius, blood pressure is 180 over 95 milligram mercury in the right arm, and 110 over 70 in the left arm. Pulse is 84 and respiration is 16. A buoy is heard over the left subclavian artery and left flank. The radial pulse is absent on the left side, and the dorsalis pubis pulses are absent bilaterally. Labs, hemoglobin is 9.2, leukocyte count is 14, platelet is 575, ESR is 125, creatinine is 1.1, UA is normal, and chest X-ray is normal. Which of the following is most likely cause of this patient's hypertension?
What do you guys think? Yeah, so on your boards, they're going to show you a picture of a renal angiogram, and you're going to see the microaneurysms. You never answer that the next step is do a renal biopsy because these patients bleed. They can actually die. It's a contraindication to do a renal biopsy in somebody with polyarteritis nodes. And what I'm trying to point on this person is that she has renal artery stenosis because she's inflamed. You know, vasculitis. Patients with renal artery stenosis, there's two types. The elderly with coronary disease, we call that atherosclerotic renal artery stenosis, and we have the younger with either fibromuscular dysplasia, which is the typical, you know, like genetic condition predisposing, versus the patients with vasculitis. And that's the reason why I put this question. So renal artery stenosis, this person has vasculitis in many places. When they check her arms, blood pressure was very high in one arm because of the bruit that we heard in the subclavian area. And she also has like an abdominal, you know, like abdominal bruit. So this person has renal artery stenosis. And this is an important consideration because we get taught in medical school that it's always related to cholesterol buildup or fibromuscular dysplasia. No, it actually happens in the setting of vasculitis, radiation, like cancer survivors. We see patients with severe hypertension related to renal artery stenosis, and any patients with a history of abdominal trauma. So this person has vasculitis. So vasculitis is a very complex topic in rheumatology. On your boards, what you need to know is at least the small vessel vasculitis, some of the medium vessel vasculitis, and the large vessel vasculitis. So this slide is pretty comprehensive. So we have the small vessels, we have the ANCA positive. We know that there's 3 of them. The MPA, microscopic polyangiitis, Wegener's. We don't call it Wegener's, we call it now, how do we call it? Yes, remember how we call it?